Alright, here we are for Radiology Rapid Review Part 2. So essentially what we're going to do, I'm going to go over 3 cases, show you the images, give you about 30 seconds to review the images. After that, we'll go over the relevant findings. So let us begin. Alright, case 1, image 1 of 1. Okay, so we have a contrast-enhanced CT of the abdomen and pelvis here, and what do we notice? In the anterior aspect of the left upper quadrant, we have this ovoid fat density structure, quite large, measuring close to 5.9 centimeters. We notice that there's some surrounding mesenteric fat stranding and some overall surrounding inflammatory change. What does that make us think? This actually ends up being an omental infarct. Now, what's another differential for an omental infarct? Something like epiploic appendicitis. Epiploic appendicitis is another fat infarction. However, that usually occurs closer to the colon and closer to other abdominal viscera. It's usually smaller. That kind of helps to distinguish it. But these two entities are very difficult to distinguish. But this is an omental infarct. Now, what's important about this is that they present like almost such as an acute abdomen. However, these are managed more conservatively. So this is a good example of a pretty large omental infarct in the left lower quadrant. Case 2, image 1 of 1. So what do we have here? This actually was called down as a code stroke. So essentially we see this almost bilobed structure, hyperdense structure in the region of the midbrain, and we happen to see even a little bit of extension into the third ventricle. This happened to be an acute intraparenchymal intracranial hemorrhage, midbrain bleed that happened to have some intraventricular spread within the third ventricle. The other ventricles are not well seen on this particular image, but there was no hydrocephalus. Now, anytime you have intraparenchymal hemorrhage, the next thing you have to assess for is associated vasogenic edema, mass effect, herniation. So now in this situation, we have the midbrain here, but we're not able to really make out any of the basal cisterns. So there is some associated mass effect with effacement of the basal cisterns. We don't see the interpeduncular cistern, we don't see the ambient cistern, we don't see the quadrigeminal cisterns. So there is a little bit of associated mass effect. So this code stroke patient actually ended up having an acute intracranial hemorrhage with ventricular extension without evidence of hydrocephalus and small amount of mass effect with effacement of the basal cisterns. All right, last case. Case 3, image 1 of 1. Okay, so here we have a contrast-enhanced CT of the abdomen pelvis, and we have this area here of almost circumferential wall thickening involving the sigmoid colon as well as the rectum. We also see some perirectal mesenteric fat stranding and overall surrounding inflammatory change. These findings are highly suggestive of an acute colitis. Now, what's the cause of this colitis? Can we really say on imaging if it's an ischemic colitis, an infectious etiology, or an inflammatory colitis? Very difficult to say, but we do happen to see, given the clinical history, this looks like an acute, likely infectious colitis. However, given the fact of the circumferential wall thickening nature of it, an underlying malignancy, let's say, is hard to fully exclude. So in a situation like this, we'd recommend, that likely this looks like an infectious etiology of the colitis, but however, upon resolution of the symptoms, patient would likely benefit from a colonoscopy just to make sure that we're not missing any underlying malignancy. It's hard for us to tell just in a setting like this, so we have to correlate with what we see on imaging with what the clinical picture is. So that was that. rapid radiology. Part 2, another 3 cases, live cases. Let me know what you think. Let me know your thoughts. And until next time.